Hey guys, how's it going? This is Dr. Kareem Godil. Welcome back to the channel. Today I want to talk about a little bit of a sensitive topic, and that's basically end-of-life care in the acute setting. Now, this is a very personal topic, so I don't want to sway you in one way or another. I just want to talk to you about the facts. The reason being is because I see this all the time in the hospital. I deal with it maybe daily or every other day basis. I'm not in the critical care setting. I'm on the floors and the wards, and I still deal with this all the time. If you could please like and subscribe, I'd really appreciate it. If you have future video comment ideas, please leave it in the comments below. Now, what do I mean when I talk about end-of-life care in the acute setting? I want to play a scenario for you. You have an 80-year-old gentleman, past medical history of well-controlled diabetes, hypertension, able to function at home. He has all of his ADLs, able to walk upstairs, able to do his own grocery shopping, balancing his checkbook. High-functioning geriatric patient. All of a sudden has a heart attack, calls an ambulance, is rushed to the hospital, and now there's so many people asking all these questions, you get confused, you don't have any idea of what you want to do, so you say, ask my daughter, ask my son. Now your kids have no idea exactly what the father wants. And there's a lot of confusion that happens, and a lot of delay of care, delay of wishes that the patient actually wants but has never actually thought about these things. Or sometimes it's due to kidney failure or liver failure or an overdose accidentally on toxins because they were dehydrated, kidneys started to fail a little bit, and the medications that they were taking just made their kidneys worse. And now there's so many toxins in the systems that they're in a stuporous coma and they can't make decisions for themselves. And the kids have no idea what the wishes are for their parents. Now in the acute setting, there's a couple of things I want to talk about. The first one is going to be DNR, DNI. The second thing is going to be dialysis. Now, what is DNR, DNI? DNR basically stands for do not resuscitate, and DNI means do not intubate. Now, we see resuscitation all the time on TV. That's where we take our hands, put them on the chest, and start doing chest compressions to bring a person back to life. Now, TV glamorizes this and really makes it so that usually you have to do the chest compressions for a few seconds, and then the patient's back up, walking, talking, doing all of their normal activities. In reality, that does not happen. What chest compressions really are is we break ribs, and we have to press so hard we're physically pumping your heart from the outside in. So there's so much pressure we're literally breaking ribs. It's not a pleasant experience to have. To explain that in an acute setting is very difficult to do. Right now I can explain it on a PowerPoint, I can go on my iPad and draw it for you like my other lectures. But in the acute setting, you only have what's in your pockets. You don't have an iPad all the time. You don't have a PowerPoint that you can just show and the patient will understand or the families will understand right away. There's so many other things that they're thinking about, right? Because by the time they even set foot in the emergency room, they've called an ambulance. They've called family members. They've been seen by medics. They've been seen by the nurses. They've been seen by the emergency room doctors. They're seen by the hospitalist and any specialists that have needed, the cardiologist, the nephrologist, the hepatologist. So it's very confusing for so many people in such a short amount of time to explain these things. So how do I explain it to my patients? The way that I explain it to my patients is what I have in my pocket. What I have in my pocket is usually a piece of paper, usually my list, which is a paper. It will be represented by a box. Now this box has a line, point A and point B. Now this line, that's kind of hard to see here, is going to represent life. Everybody is born here and everybody dies here. Okay? Nobody can tell you how long this line is. 50 years, 100 years, 3 months, 3,000 years. Nobody can tell you. If you believe in God, only God can tell you. DNR basically means is when you have a cardiac arrest. Having a cardiac arrest means you're here. You're off the line. You're not on here. And sometimes, if we're lucky, by doing chest compressions and putting a tube in your mouth to breathe for you, we're able to bring you back on the line. Well, what are the percentages? The percentages are, if you're outside of the hospital, it's roughly a 10% chance that you can come back on the line. If you're in the hospital, because there's so many trained professionals around, it's around 20 to 30%, not much higher. Now let's say we do chest compressions, we put a tube in you, we get you back on the line. What's the quality of life after? Is it like they show in TVs where you're able to play golf right away? Or is it something different? Usually it's something different. The reality is, a lot of times you're in a coma that you never wake up from. If you do wake up, You have to do weeks of inpatient rehab, weeks of rehab facilities, months, 6 months, even a year almost, for you to gain back some functional strength. And even then, because of the fact that there was no oxygen to the brain, you will probably have residual deficits. And your heart usually stops beating for a reason. It doesn't stop beating by itself. You have that issue to worry about as well. I hope that explains kind of what resuscitation is in terms of what DNR is. What DNI is intubation. Do you want to be intubated or do you not want to be intubated? Now, there's many reasons why, as a clinician, we would recommend being intubated. The first one, obviously, is you can't protect your airway. If you can't protect your airway, you're not going to be able to breathe. You're going to suffocate on your own tissues, and you're going to pass away. What causes that? You're in a coma for some reason, either medication-induced or from a toxin buildup from liver failure, kidney failure, or usually a combination of both of these things. The other reason why we intubate people is with asthma exacerbations, COPD exacerbations, or other diseases of that sort, where it's just hard for you to maintain adequate either saturations or just breathing at a normal rate. The example I usually give to my medical students or residents is, let's say you're on a track and you're running around this track. Now I ask you to, hey, I want you to sprint 2 laps around this track. How are you after you sprint? Are you like breathing like me right now at a normal rate? Or are you huffing and puffing and your neck muscles are flaring, your nostrils are flaring? And the reason for this is because your diaphragm can't keep up with the oxygen demand. Now, in those diseases that I mentioned earlier, you're like that, but after you run, after 5 minutes or so, you're back to normal. In those diseases, you're not back to normal. And you're like this for minutes, and then you're like this for hours, and then almost a day. And eventually those muscles, since they're not used to being worked so hard for so long, they fail. Unfortunately, that's what happens. That's a reason why we intubate patients, usually a little bit earlier or a little bit later, but we want to intubate them before you fail. That's what DNR is. That's what DNI is. Now, it's a personal decision in the hospital to say, I want to be a DNR or a DNI. It's a conversation you need to have with your family members, your priests, your rabbis, your people that you trust. And you have to also take in your comorbids. If you have uncontrolled diabetes, uncontrolled hypertension, it's going to make it that much harder for you to recover. Now, what have some of my patients said to me in the hospital when I have asked this question? Now, when I have asked this question, what have my patients told me? My patients have told me a few different things. One of them has said, hey, I'm 80 years old, I've lived a good long life, all my friends have passed away at this point, I don't want to be in a coma or stuck on a tube or with a feeding tube or any of these things. If it's my time to go, it's my time to go, make me comfortable, period. Whereas other people say, hey, my grandchild's birthday is in a month or in 6 weeks or in a year, and I want to stay alive as long as possible for that. They have some goal or some time set in mind that they want to live towards, and they want to do everything as possible to get to that point. There are no wrong answers. Now, there are going to be times in the hospital where, as a physician, I will recommend you to be DNR, DNI. It's very seldom that I recommend this, but the situations that I do recommend being DNR, DNI is if, one, I anticipate that the patient is going to have a cardiac arrest or they're about to jump off that line and into the dead zone, where we would have to try to do chest compressions and break their ribs to bring them back onto the line. And the reason why I, as a physician or other physicians, recommend not being resuscitated in that scenario is if, one, we don't think we'll be able to bring them back. That means they're so sick that we think that they're probably going to pass away fairly soon due to either toxins building up in their system, and it's just not reversible. And so that instead of doing chest compressions, breaking ribs, putting a tube in their throat, we would recommend having them pass comfortably. It's a personal decision. I understand it. We all do. But the point of this video really is to have these conversations to happen sooner rather than later. I do not want to have these conversations when you're in the hospital where 50 different people are talking to you, half of them are physicians, and everybody's saying it their own way, and I don't know you. I was not your family doctor for 20, 30 years. I am some random guy that you're trusting your life with. So what I recommend is for you to talk to your family doctor about this, and your family doctor should be talking to you about this. In fact, if you're on Medicare, Medicaid, your family doctor every year should be talking to you about this because it's a requirement from Medicare. The second thing I wanted to talk to you about is dialysis. Now, why talk about dialysis? Hey doc, I don't have kidney disease. I have some controlled hypertension, I have controlled diabetes, but nobody's ever said anything's wrong with my kidneys. I don't want to talk about dialysis. My brother had it, my cousin had it, my friend had it. It was horrible for them. Nothing's wrong with my kidneys. I don't want to talk about it, doc. Well, I want you to talk about it. The reason I want you to talk about it is, yeah, you have controlled diabetes, you have controlled hypertension. Let's say something were to happen and your kidneys were to fail. Why do they fail? Usually I like to think of it as a boxing match. It's never one right hook that's going to knock you out. It's always a few jabs. Hypertension, diabetes, heart attack, shock, medications. And all of these things, all of these jabs have really hit the kidneys a contrast load, right? Coming out of nowhere for some emergent imaging. Now all of a sudden your kidneys are at the point where they're no longer working. They've got hit so many times, they need to recover. Now, can they recover? Sometimes. Will they recover or will they not recover? That's a discussion that the kidney doctor will have to happen with you. A lot of the times they do recover. Is it a slow recovery? Usually. Is it a long recovery? Probably. But can they recover? Yes. Do they always recover? No. What do we need to do in the meantime to give them time or to buy enough time for them to recover? That is dialysis. Now, if you have a family friend or you know somebody that was on dialysis, you know it's not fun. You have to go to a dialysis center 3 times a week, Monday, Tuesday, Wednesday, or Tuesday, Thursday, Saturday, for 4 hours. And your body is draining its blood, or this machine is draining your blood, filtering out all the toxins, and pushing it back in. It's not a pleasant experience. Ask anybody. By the time it's over, they're fatigued, they're drowsy, they're just... Now, I haven't really talked about hospice care, palliative care, in end-of-life settings. I've really talked about DNRT9 emergent dialysis if needed. It's very personal decisions. I understand this. That's why the point of this video is for you to talk to your family members, your friends, before it happens, so that when it does happen, you are prepared, your wishes are well known. Because the last thing I want to do is to do something against your wishes. The last thing your family wants to do is to do something against your wishes. We all want to kind of be on the same page here. We hope for the best, but prepare for the worst. So that's the end-of-life acute care talk in a nutshell. If you enjoyed, please like and subscribe, or if you found it interesting, please like and subscribe, because I know this video is slightly depressing. If you have any comments or ideas for future videos, please let me know. I really appreciate it. Thanks for watching. Bye.